Yes, please.
Okay, so today we are going to look at the peritoneum. Who can define for us what the term peritoneum means? Anyone by show of hands? Anyone to define for us what the term peritoneum means? Yes, Godfrey.
Peritoneum is a serous layer or a serous tissue that covers organs, that lines organs in the abdomen.
Okay, so thank you. Yes, David, you wanted to add on? Okay, so yes, Marriott.
A peritoneum is a slippery, transparent membrane covering inside organs in the abdomen.
Okay, so it's a serous membrane, just like how you remember the plural, the pericardium. This is a serous membrane enclosing the organs in the abdominal cavity, as you can see here, but also lining the inner aspect of the abdominal wall. So what you see here in green, enclosing the organs and reflecting to line the inside of the abdominal wall in green, that is our peritoneum. Okay, so it's a serous membrane, and you know what serous membranes are. These membranes are unique. They are made up of what we call mesothelial cells, cells that have the capability to secrete fluid. Okay, so this membrane here, it's double-layered. There is an inner part that we shall call the visceral layer, then the parietal. The visceral, it's close to the organs, because the word viscera means organs. The parietal, it's close to the wall, to the abdominal wall, because the word parietal means wall. And it's what you're seeing here. This is the visceral. It reflects onto the wall to become the parietal. Okay, so these two layers are continuous with each other and separated by a space that we call the peritoneal cavity. It's called a potential space. Why is it called a potential space? Anyone to tell us? In your reference textbooks, you always see that term, potential space, potential space. What is a potential space? What does that term mean? Anyone to tell us? What does that term mean, potential space? Yes, Godfrey?
according to me, I think potential, it means like it's an approximation or a space that it is not there, but it's like they think that it's they think like it is there.
Okay. Okay, Apophia.
A potential space means that it is a space between two adjacent structures that are normally placed together.
So these are called potential spaces. Remember our pericardial cavity, our pleural cavity, and this one also. They are called potential spaces because they are spaces between two layers that are adjacent to each other, creating just a small gap between, a gap that can easily widen in case there are pathological fluids. It's not a real space, but it can become a big space in case of accumulation of fluids, pathological fluids, whether blood, whether pus, okay, it can be widened. Okay, so that's why they always use the word potential space. That space, there's a potential for that space to widen in cases of pathologies. Okay, so normally within this space there is some fluid, about 50 to 75 mils of fluid, and this fluid basically lubricates the tissues that lie in the abdominal wall and the viscera. So remember, always your intestines are always moving during digestive movements. There will be some peristaltic movements that will make your intestines to slightly move within your abdomen. And it's important that there is always frictionless movements. And that's possible because of the fluid that we are calling the peritoneal fluid. Okay, so as we can see, we said we have a part that lines the organs. You can see this in purple here. It reflects onto the wall to become the peritoneum that is going to line the wall. And if you look closely, between the peritoneum and the viscera, there is a space that we call the peritoneal cavity, a space which is going to contain fluid. Look closely, you can see that within this space we only have fluid. Our organs are not within this space. Our organs are just wrapped around by the visceral peritoneum, but they are not in the space. This is the space there. Okay. Similarly, you can imagine using this analogy, an inflated balloon. If you put your fist into an inflated balloon, that layer of the balloon close to your fist, you can imagine it to be the visceral layer. Then the one that is far away from the fist, that is the parietal layer. Between the two, we have a space that now we are calling the peritoneal cavity, containing only fluid. Your organs are outside. Your organs are just wrapped around by the visceral peritoneum. Okay? So hope that is clear. This picture can further add on to what I've said. You can see the visceral peritoneum. So it reflects onto the abdominal wall to give us the parietal peritoneum that will line the inner aspect of the abdominal wall. But also, this parietal peritoneum, it extends deep into the pelvic cavity to also line the organs of the pelvic cavity, as we shall later see. As you can see here, it continues upwards to line the inside of the posterior abdominal wall. Our visceral peritoneum, we said it's going to extend posteriorly towards the abdominal wall, and that extension of the visceral peritoneum towards the posterior abdominal wall, we call it the mesentery. Okay. This mesentery is going to serve as a pathway for blood vessels. It's going to serve as an anchoring point that will allow your intestines to easily float within the abdominal cavity. Okay. The whole of this space from the abdominal wall anterior to the posterior abdominal wall, the whole of this large space is the abdominal cavity. Okay. Within the abdominal cavity, we have the peritoneum, the two layers, okay, the inner layer which is enclosing our organs, the parietal layer which is lining the abdominal wall, and between the two, you have the peritoneal sac or the peritoneal cavity, which is going to contain fluid, only fluid. So don't confuse the peritoneal cavity with the abdominal cavity. The abdominal cavity is that whole space enclosed by the abdominal wall. Okay? The peritoneal cavity, it is that space between the peritoneal layers, and it only contains fluid. Hope that's clear. This image is further telling us about the same. Our visceral peritoneum, it is seen wrapping around the intestinal structures, extending posteriorly to reflect onto the abdominal wall. And see it's reflecting onto the abdominal wall anteriorly here to form what we call the parietal peritoneum. And the space between these two is the peritoneal cavity. Appreciate that the parietal peritoneum doesn't only line the inside of the abdominal wall, but it continues down to line the organs of the pelvic cavity. You can see that here. The urinary bladder, it is going to be wrapped around the uterus, the rectum, of course in women, it's going to be covered by this layer that we are calling the parietal peritoneum. Okay, so that is how your layers will extend. Within the peritoneal cavity, we have mentioned that we have fluid. This fluid is going to be circulating around within the peritoneal cavity. You can see it circulates around the liver, downwards along the colon towards the potential spaces within the pelvic cavity. So this picture is just to give you an understanding that the fluid that runs within the peritoneal cavity in the abdomen extends into the potential spaces within the pelvic cavity. And those potential spaces, we shall see them later. Okay. So right now, just understand that that fluid does not only circulate within the abdomen, but it can extend downwards. For example, when the patient is in a standing position or an erect position, that fluid can extend downwards into the potential spaces of the pelvic cavity. That's why later we shall learn that patients with ascites, they will have too much of this fluid and it will extend downwards to overfill the potential spaces of the pelvic cavity. Okay, we shall talk about that later. In this slide, you can see that the peritoneal cavity of the male, it's structurally different from the peritoneal cavity of the female. The peritoneal cavity of the male is closed. The one of the females is not closed, it's open to other structures. You can see it here. This is the peritoneal cavity of the females. It's going to communicate with the fallopian tubes. You can see the tubes. These are the tubes. Okay. You all know that the tubes have these ends that we call the fimbri. These fimbri are going to be having a contact with the ovaries, but also these fimbri are going to be opening. You can see the mouths are opening into the space here, which is the peritoneal cavity. Okay, that's why we are saying that the peritoneal cavity in females, it's open because of the communication with the fallopian tubes or the uterine tubes. And that means what? What's the clinical aspect that may be related to this? Anyone who can tell us? Having known this, what do you think can happen? Yes, Agnes.
This will increase infections in women from the exterior environment to the inside.
So, because of the communication between the peritoneal cavity and the female reproductive structures, it's possible for infections spread from the peritoneal cavity. If a lady has peritonitis, let's say because of some bacteria causing irritation of the membranes of the peritoneum, there's a chance of these infections to spread to the fallopian tubes. Okay. At the same time, if a patient has got, let's say, salpingitis, or what we call inflammation of the fallopian tubes because of the pelvic inflammatory disease, it's possible for these infections to spread into the peritoneal cavity, resulting into peritonitis. So there is that possibility of infections to easily spread, okay, because of an open peritoneal cavity in females. Additionally, it's possible for menstrual blood to move in a retrograde fashion into the spaces around the ovaries. Okay, we know that menstrual blood has to flow downwards, okay, in the anterograde fashion, downwards, but it's possible in approximately 90% of the women, it's possible for this blood to flow in a retrograde fashion, and once it flows in such a manner to enter the tubes and and spill into the pelvic cavity, or you can see into the peritoneal cavity. And once this happens, it increases chances of what we call endometriosis. Some women that experience this can have endometriosis because this menstrual blood has got endometrial cells that are sloughing off from the endometrium. So these cells, once they plug themselves onto the structures in the structures that are into this space, for example, the intestinal structures, the ovaries, once these cells plug themselves onto those structures, it's going to result into what we call endometriosis. Endometriosis means growth of endometrial tissue outside the uterus. Okay. This endometriosis, I have said it's going to occur in such women. So having retrograde menstrual blood flow, it's a risk factor to endometriosis. People with a weak immune system, they are going to experience also endometriosis. There are some genetic factors. Some studies show that endometriosis can run in families, so that's why I'm saying there is some genetic predisposition. Some environmental factors that can lead to endometriosis. If that is exposed to chemicals like pesticides, those things contain substances that can affect or result in endometriosis. So there are many postulates or many factors that are believed to be associated with endometriosis. But this is one of the factors. Ladies that experience retrograde menstrual blood flow are going to stand a high chance. Almost 15% of these can have endometriosis. This is because of the free communication between the tube and the surrounding structures. I mentioned this already. Because of the free communication between the female reproductive structures and the peritoneal cavity, it means that it's possible for infections to spread from the peritoneal cavity itself down into the female reproductive structures. And also it's possible for infections to spread from the female reproductive structures towards the peritoneal cavity. So in this image you're seeing, someone has an STD caused by, can be any bacteria like chlamydia. This infection can spread through the tube to affect other structures within the pelvic cavity or the peritoneal cavity. It's believed that whenever infections spread in such a way, it can easily, of course, you can see the pathway that our fluid can take, as we explained previously. Our fluid can take this path to rotate around the colon, the ascending colon, the liver, and then this side rotate around the sigmoid colon, the descending colon. So these are routes. So whenever such a thing happens, it's possible for these bacteria to spread towards the liver. And once it reaches the liver, it will cause formation of adhesions within the capsule or the outer covering of the liver, resulting in what we call perihepatitis. The liver is inflamed, but on the outer aspect. Okay? This is because of a pelvic inflammatory disease. If a patient has got a pelvic inflammatory disease as a result of this bacteria, this disease can spread to affect other organs. Okay, that kind of syndrome is called Fitz-Hugh-Curtis syndrome. Okay, it's a major complication seen in some ladies that have PIDs or pelvic inflammatory diseases. They will tend to feel pain in the right upper quadrant, and that will be a signal that these infections are not only in the pelvic cavity, but they are also spreading into the structures of the abdomen, and in most cases they do spread to the liver because of the fact that this path is allowing the fluid to extend to the liver easily when the patient is in a spine position. Okay, so now let's look at the relationship between the viscera and the peritoneum. There's a way how your visceral structures are related with the peritoneum. You can see here there are some structures that are almost enclosed by peritoneum and suspended to or from the abdominal wall by these structures that we call mesenteries. Such organs, we call them intraperitoneal structures. Intra doesn't mean that they are within the cavity. You can see the cavity is free, it has only fluid, but they are almost enclosed by the visceral peritoneum, and they are suspended to the abdominal wall or from the abdominal wall by these extensions of the visceral peritoneum that we call the mesenteries. Then we have some structures that are not suspended in the abdominal cavity by a mesentery, and these structures lie between the parietal peritoneum and the abdominal wall. Or you can say structures are behind. They are behind the parietal peritoneum. They are against the abdominal wall and behind the parietal peritoneum. These, last time we called them retroperitoneal structures. So structures that we call intraperitoneal include our small intestines, specifically the coils of the jejunum and the ileum. Those coils, they are what you see here. Those coils, they are going to be suspended in your abdominal cavity with the help of these structures that we call the mesentery. These structures, they are going to be connecting your organs or tethering them indirectly to the posterior abdominal wall. And that allows your intestines to be free, okay, within the abdominal cavity. Them being free can be a disadvantage. Why? Who can tell us? Why am I saying that? Yes, Marriott.
In case the mesenteries have loosened, there will be prolapse of that specific organ that is attached by the mesentery.
There will be, I missed that.
There will be a prolapse of the organs.
Not prolapse. Anyone to use the right word? Anyone to try? When the mesentery is loosened, something can happen. No, it's not prolapse, but what is it? these intestines are free, and there's a higher chance of these structures twisting upon themselves, leading to what we call volvulus. Okay, one of the causes of intestinal obstruction. Okay, so when they twist upon themselves, they can be an obstruction because of that. But the advantage here is that the mesenteries, they're going to provide a pathway through which blood vessels will pass. For example, you can see this is our abdominal aorta. It gives off blood vessels that enter the mesentery to reach your coils of the intestines. The veins also traverse through this, the lymph vessels, the nerves. So it's a conduit for neurovascular structures to and from the small intestinal coils. Okay, so those are the intraperitoneal structures. Examples, we've mentioned the jejunum, the ileum. The sigmoid colon is also an intraperitoneal structure because we are going to later see that there is a connective tissue that will help it to be suspended from the posterior abdominal wall. Okay, the transverse colon, the cecum, all these are intraperitoneal structures. These structures are free. For example, when you open up a human body, like as you see here, they are going to be free. Those are the intraperitoneal structures. Then we have the retroperitoneal structures, or you can call them extraperitoneal structures. These are behind the peritoneum, and they are lying against the posterior abdominal wall. Obviously, you can see that we have the kidneys, okay. We can see that we have, of course, the glands on top of the kidneys. Those are the suprarenal glands or the adrenal glands. The ureters that are coming off from the kidneys, you can see the ureter there, okay, and you can see also it is here. They are behind the peritoneum, the peritoneum, lying close to the posterior abdominal wall. Then the duodenum, the bigger part of the duodenum, it's retroperitoneal, situated behind the peritoneum. The pancreas, you can see it, the bigger part is retroperitoneal, behind the peritoneum. The aorta, the inferior vena cava, these big vessels, they are behind the peritoneum, against the posterior abdominal wall. You can see that they are very well. That's the aorta there, that vessel in red, that is the aorta, that's the IVC. Okay. There are many nerves, now neurostructures. Okay. The ascending colon, it's supposed to be here. It's also retroperitoneal. It's tethered directly to the posterior abdominal wall. The descending colon is also tethered directly onto the posterior abdominal wall. So these structures, we call them retroperitoneal structures. They are close to the back, not to the posterior abdominal wall. Because of this, that's why whenever patients, let's say, get kidney stones, pancreatitis, usually these patients will feel pain in the back because these structures are close to the back, or to what we are calling the posterior abdominal wall. Okay. If this patient gets an obstruction in the ascending colon, descending colon, they will feel pain radiating to the back because the structures are close to the back. Okay. So those are retroperitoneal structures. Next, let's talk about the peritoneal folds. So our visceral layer of the peritoneum, we said, it's going to envelop the intestinal structures. But it doesn't only do that, it's going to form extensions, or what you can call peritoneal folds, that will help in connecting the structures or binding them together or with the abdominal wall. Okay, so these peritoneal folds are just extensions formed by the visceral layer of peritoneum. So we have the mesentery, we've already talked about this. We have the mesocolon, the omentum, the ligaments, all these, we can talk about them now. The omentum, these are two. We have the greater omentum and the lesser omentum. You can see that these are peritoneal folds that help in connecting the stomach to the neighboring visceral structures. Okay, the big one is the greater omentum. This small one is the lesser omentum. The greater omentum, it's a peritoneal fold that largely contains adipose tissue. Okay, and it's going to be like an apron connected to the greater curvature of the stomach downwards, as you can see. It's going to be attached to the greater curvature of the stomach, and it's going to extend downwards to cover the coils of the intestines. Largely, it is made up of adipose tissue, and this can somehow cushion your intestines from external injuries, but also this great omentum, it is made up of abundant immune cells, specifically macrophages. And because it's made up of too much macrophages, it means that it can somehow contribute in limiting the spread of infections within your abdomen. That's why it's called the policeman of the abdomen. For example, if a patient unfortunately has, let's say, chronic ulcers in the stomach, if, let's say, those ulcerations cause perforations or holes within the stomach, of course we know that the stomach contents can easily leak into the abdominal cavity. So usually in such scenarios, this great omentum can limit the spread of those stomach contents in the abdominal cavity by extending towards the stomach. Okay. In the second scenario, if a patient has, let's say, ruptured appendix, we have an appendix here, small structure connected to the cecum. If a patient has a ruptured appendix, this great omentum is going to extend downwards to the right and surround that area and limit the spread of those contents from the appendix, because if they overspread around, it can lead to peritonitis. Okay, so in patients with a strong immune system, and let's say those patients have a ruptured appendix or a ruptured gastric ulcer, the effect may not be so worse because the great omentum is going to act as the policeman of the abdomen to come in and limit the spread of infections. Surgically, this great omentum can be of importance. Let's say if there is some part of the body that is diseased, part of this KY.ANATOMY can be cut and be plugged to that part of the body that is diseased, because we know that it has immune cells that can allow quick healing of that given part of the body. Okay, so it can be surgically used as a graft to allow quick healing of several parts of the body. The lesser omentum, it is a peritoneal fold that is double layered. It's going to be connecting, as we say, it's going to connect your stomach to the surrounding structures. To be specific, it's going to contain this, it's going to connect the stomach and the first part of the duodenum. This is the stomach, this is the duodenum beginning, okay? It has 4 parts, there is 1 part here. This is the first part, okay? So the lesser curvature of the stomach plus the first part of the duodenum, they are going to be attached to by the lesser omentum, and it's going to extend upwards to attach on the visceral or on the inferior surface of the liver. Now this lesser omentum, it has 2 parts. That's extension from the stomach to the liver, we call it the hepatogastric ligament. The extension from the duodenum to the liver, we call it the hepatoduodenal ligament, just from the names themselves, the names of the structures being connected. So you can see that normally within the hepatoduodenal ligament, there are going to be some structures that are going to be running to and from the liver. These structures include the bile duct, okay. We have the hepatic artery. It's going to nourish the liver. The hepatic portal vein, it's transporting nutrients to the liver, okay. So these 3 structures, they are going to be within the hepatoduodenal ligament, which is part of the lesser omentum, okay. So that's important there. So that's the lesser omentum. That's the lesser omentum. Beneath the lesser omentum, beneath the right free margin of the lesser omentum, there is an opening that we call the epiploic foramen. This opening leads you to a space that we call the omentobursa. Okay, there is a space beneath this ligament that we call the omentobursa, and it's entered too with the help of this epiploic foramen. So basically, just beneath the right free margin, we have an opening that leads you to a space that we call the omentobursa. The omentobursa is shown here, just that space underneath the lesser omentum, and it normally contains some fluid. We shall talk about it later, okay? But in this picture, appreciate that we have the greater omentum and the lesser omentum. The greater omentum, we say it extends from the stomach downwards, like an apron, to cover these coils of the intestines. And the lesser omentum, we said it's going to extend largely from the stomach to the liver. And we said beneath it there is a space that we call the omentobursa, or the lesser sac. Okay. we're going to talk about it more. So far we have seen two peritoneal folds, the greater omentum, we've seen where it's situated and its function. Then the lesser omentum, we've seen that it helps in connecting the stomach to the liver, but also some part of it contains the bile duct, the portal vein, and the hepatic artery. That part was the hepatoduodenal ligament. Okay, so that's the greater and the lesser omentum. Next, let's talk about the mesentery. The mesentery, it's a term given to that peritoneal fold or peritoneal extension that help in suspending the coils of the small intestines from the posterior abdominal wall. That peritoneal extension there that suspends these small intestinal structures or from the posterior abdominal wall, that one there, it's what we call the mesentery. Some sources call it the mesentery of the small intestine for clarity. So it is that structure there, that broad fan-shaped structure. Okay, it's going to run from the posterior abdominal wall and suspending your intestinal structures freely within the abdominal cavity, as you can see here. That is the mesentery. This mesentery is going to contain structures, of course, that are going to be running to and from your coils. We said earlier that blood vessels that come from the aorta, blood vessels that are going to nourish your intestines, they are going to go through the mesentery to reach the intestinal coils, the small intestinal coils. And those blood vessels are specifically called the superior mesenteric artery. The superior mesenteric artery is one of the arteries that come off from the abdominal aorta and then go through the mesentery to divide into many branches, jejunal branches, ileal branches that are going to nourish the jejunum and the ileum. So all that will be going through the mesentery. Lymphatics from these coils here, they are going to be going through the mesentery. There will be so many lymph nodes within the mesentery. Autonomic nerve plexuses that are controlling the gut or the function of the small intestines, they are going to be within the mesentery. This mesentery is also going to contain fat. And because of the fact that it contains fat, we shall later learn that can predispose to diseases. When we get to the small intestines in detail, we shall learn that this, too much fat, can predispose to diseases. How? We shall learn when we get to the small intestines. There are some people that are not muting themselves. Prosper, please. Keep yourself muted. Natumanya Prosper. Okay. The next peritoneal fold, it's the transverse mesocolon. The transverse mesocolon, it's going to suspend your transverse colon from the posterior abdominal wall, as simple as that. The sigmoid mesocolon, it's going to suspend your sigmoid colon from the pelvic wall. Okay, and we can see this here. This is the ascending colon. This is the transverse colon. This down here is the sigmoid colon. The descending colon is short behind these coils. You can't see it fully, but we have the ascending, the transverse, a small descending colon, and then the sigmoid colon. So from your transverse colon, there is this peritoneal fold that we call the transverse mesocolon that will be connecting your transverse colon to the posterior abdominal wall, and that allows your transverse colon to hang freely within the abdominal cavity. It's not like this ascending colon which is tethered onto the posterior abdominal wall. No, it's not like the descending colon which is tethered onto the posterior abdominal wall. For it freely hangs within the abdominal cavity. And because of that, it can have multiple positions. In some patients, this transverse colon, it can sag down to reach the pelvic region. Okay. In some patients, it can just be in the umbilical region. In some patients, it can be in the epigastric region. It depends on the length of the transverse mesocolon. If it's long, this will extend deep into the pelvic cavity. So knowing this, of course, it can guide you whenever you're scanning. There are structures that have fixed positions, like the ascending colon and descending colon. They are retroperitoneal, and they are fixed onto the posterior abdominal wall. The transverse colon, these coils here, they are slightly mobile, or they are just hanging in the abdominal cavity, and their locations are not fixed. So that is the transverse mesocolon, connecting your transverse colon indirectly to the posterior abdominal wall. The mesentery, as it has been cut out here in this image, it was connecting your small intestinal coils, okay, indirectly to the posterior abdominal wall, allowing them to freely hang in the abdominal cavity. But those coils have been removed, they are not here. Then you can see our sigmoid colon. It is going to be indirectly connected to the posterior abdominal wall by what we call the sigmoid colon. The sigmoid mesocolon. The sigmoid mesocolon is going to allow our sigmoid colon to freely hang within the pelvic cavity. Okay, within the pelvic cavity. So, because of the fact that this sigmoid colon can also freely hang within the pelvic cavity, it also poses a risk of abnormal twisting, or what we call volvulus. Okay, we said volvulus must be seen in the small intestinal coils because they are freely hanging and they are long, but also it can also be experienced in the sigmoid colon because it is freely hanging within the pelvic cavity. So these two, the coils of the intestine and the sigmoid colon, they are predisposed to volvulus because of that reason. Here you can see this is the attachment of the transverse mesocolon. Okay, it has been removed. This is the attachment of the sigmoid mesocolon. That's where these peritoneal folds are attached to allow your structures to freely hang within the abdominal pelvic cavity. Okay. Going forward, next, let's look at the extensions of the peritoneum into the pelvic cavity. You can see that it extends into the pelvic cavity to wrap around the structures of the pelvic cavity. Okay, and you can appreciate it well in these images. Within the main, the parietal peritoneum that is lining the inner aspect of the abdominal wall is going to extend down to to line the superior surface of the urinary bladder, and then it will reflect onto the anterior and the lateral surfaces of the rectum. Okay, and between these two urinary bladder, okay, so my connection was interfered by a call, but let me hope I'm back. Can you hear me? Can you see the screen?
Yes.
Please.
Okay, so you can see I was saying that between the rectum and the urinary bladder, because of the fact that our peritoneum is going to reflect onto the rectum, it creates some kind of a depression between these two structures, and this is going to be a potential space that can hold some peritoneal fluid. Okay, the peritoneal fluid that is found within the peritoneal cavity, some of it can extend and lie within this space. And in cases of infections, let's say if this patient has, let's say, ascites, too much fluid in the peritoneal cavity, some of this acidic fluid or peritoneal fluid can come and fill this space. Okay. In women, the peritoneum also, it's going to line the superior aspect of the urinary bladder, the superior aspect of the uterus, and the anterior and lateral surfaces of the rectum. And because of the fact that it reflects in such a way, it creates also potential spaces. There's a potential space in front here between the urinary bladder and the rectum and the uterus. There's a potential space here between the uterus and the rectum. And this one here, how do you think we shall call it? What's the name of this space here between the uterus and the rectum? Anyone to tell us the name of this potential space? Yes, Prosper?
I think that is called the Porch of Douglas.
Yes, you can quote the Porch of Douglas. Okay, but there's also another direct name. Yes, Opok Eric. Apophia.
It can also be called cul-de-sac.
There is a direct name. Apophia.
It's called uterorectal vesicle.
Okay, this is the. I beg your pardon. You said it's called.
It's a uterorectal vesicle.
Uterorectal vesicle. That's not true. Anyone else? Let me hear from Eric again. You want to try? Yes, Lawrence.
It is called posterior cul-de-sac.
There is a direct name. This is the rectum. This is the uterus. So you can call it the recto-uterine space or recto-uterine pouch. Though in some literature it can be called the posterior cul-de-sac or the pouch of Douglas. But anatomically there is a direct name, recto-uterine pouch, as simple as that. But also just have in mind it can have those other names because you may receive medical reports having those other names and you need to reason out, understand what's being talked about. Then in front here there is a small pouch. Yes, now who can name this? What's the name of this? Yes, let's hear from Michael. Provia.
It is called the uterovesical pouch or anterior cul-de-sac.
Okay. Uterovesical. That vesicle means urinary bladder. So uterovesical pouch. Okay. Or the anterior cul-de-sac. Cul-de-sac is just a Latin term, Latin word, so it shouldn't confuse you. Okay, so then here we didn't name this in the main. How is this one named? This pouch in the main? Yes, anyone? What's the name of that pouch in the main? Still, you look at the structures close to the pouch and name it. Miss Marriott.
I think it's the rectovesical pouch.
As simple as that. It is the rectovesical pouch. Okay, rectovesical pouch. All right. So here we are seeing an image showing us the pelvic structures in the main, and our aim, don't concentrate on all this, just focus on this. Okay, so remember this was our peritoneum lining the inside of the abdominal wall. Set reflects on top of the urinary bladder and reflects onto the rectum, and we said this reflection creates a space that we are calling the rectovesical space or the rectovesical pouch there. Then in women, we said between the urinary bladder and the uterus, we have what we call the vesico uterine pouch, or you can call it the uterovesical pouch, it doesn't matter. Between the uterus and the rectum, we have the recto-uterine pouch, or what some people call the pouch of Douglas. Okay, so this potential space and this one here, they can be filled with so much fluid. Normally they contain some fluid because of the fact that they are continuous with the peritoneal cavity. So normally they contain some fluid, and usually whenever ladies go into their cycles, still there'll be some more fluid because of the ovulation that goes on. There may be some fluid that may leak into this space, which is normal. okay, because of the ovulatory cycles. But the fluid here can be so much in case, let's say this lady has got ascites. If this lady has too much fluid in the peritoneal cavity, this fluid can extend down to fill these pouches. Additionally, if this lady has got a pelvic inflammatory disease, as we explained earlier on, it's possible to have so much fluid in these spaces. Okay, mostly this one here is the one that is always looked out for because it is large and it can hold more. Okay, so in case there is a PID, the fluid here is going to be so much, and that is an indicator that this patient has got a pelvic inflammatory disease. These potential spaces are examined sonographically. In these images, we can see when you orient the probe, this is the probe or the transducer, in a sagittal manner. Of course, the waves here are going to enter the pelvic cavity of this patient and cut these organs in the sagittal plane, as you can see. And these organs can be seen sonographically, and it's the same pattern. This is the urinary bladder, this is the urinary bladder, this is the uterus, this is the uterus here, the rectum behind, the rectum behind. It appears like this because of the fecal matter that is within. So our aim here is to focus and appreciate the spaces. There's just a tiny space between these two, the urinary bladder and the uterus. That space there that we've called the uterovesical pouch. It's being outlined there. Then behind the rectouterine pouch or the pouch of Douglas outlined there. Okay. In a transverse abdominal scan, we can still see these spaces. If you orient your probe in a transverse manner with the probe marker facing the patient's right side in such a manner, in a transverse orientation, the waves are going to leave the transducer and then cut through these organs so that we get cross sections of the organs. Okay. This is the abdominal wall up here. Okay. And you can see it here also. Then we have the urinary bladder. Behind that we have the uterus. Behind that it should be the rectum. Okay. Same order. When such a plane cuts through the organs, anteriorly we shall have the urinary bladder, posteriorly the uterus, posterior to that we have the rectum. Okay, and of course this image is outlining and showing you that normally between the urinary bladder and the uterus there is some small potential space. That space there, that is the we've called it the uterovesical pouch. Then between the rectum and the uterus, there is the rectouterine pouch or the pouch of Douglas. Okay, it's larger, as you can see. These spaces or these pouches, they can be sites where fluids can accumulate. You can see this is our urinary bladder. This is our uterus. Behind it, there is a pouch of Douglas. Okay, so it's normal to have fluid in that space. It's normal. Okay, this is a transverse scan, urinary bladder, uterus. Behind it, we have the what? The free fluid in the pouch of Douglas. Okay, this is normal for the fluid to be there. this fluid can become so much, and of course you will learn how to measure this fluid. It can become so much, and if it's in large amounts, it indicates that this lady, either she's in her cycles, or of course if this lady is presenting with a protruding abdomen, it can be saying that some fluid in the peritoneal cavity, this acidic fluid has extended into the potential space. Or if she doesn't have a protruding abdomen and the fluid is so much and she's not in her cycles, obviously you can conclude that she has a pelvic inflammatory disease. There are many other factors that can lead to so much fluid in this space. You will learn about all those when you start doing the reproductive system. Here I'm just highlighting only features of importance related to this lecture. That's why I'm not going into depth of talking about the parts of the uterus or that. I'm only focusing on what we need to know as per this lecture. In this slide, we are seeing, again, it's a transverse scan, you can see, okay? And anteriorly, we have the urinary bladder, as you can see here. It's filled with urine, okay? Then posteriorly, we have the uterus. Now, posterior to this, we should be seeing the pouch of Douglas. But now, in this image, our pouch of Douglas, it is largely filled with so much fluid. So much fluid. Probably, this may be a case of a patient with ascites, because in ascites, that's when fluid becomes so much in this space. We shall learn about ascites later on. We shall see what it means, but take note that in such patients, usually the fluid is going to be in so much, in large volumes within this potential space. Okay. These spaces can also be seen when you do what we call a transvaginal scan. This scan is carried out using a probe or a transducer that we call the transvaginal probe. It's called transvaginal because it's going to be inserted into the vagina, and once it is inserted into the vagina, of course, to give us clear picture of the female reproductive structures. You can see our uterus here, okay? Behind it, we know we have the pouch of Douglas. Okay, between the uterus and the rectum, we have the pouch of Douglas. And we say it's normal to have some free fluid in this space. If the fluid is too much, that's a sign that there may be some infection, okay, among other disease scenarios. But most cases, the sign that this lady has a pelvic inflammatory disease. Okay, let's subdivide the peritoneal cavity. It's subdivided into two. We have the greater sac, we have the lesser sac. The lesser sac can also be called the omental bursa, and I have already shown you this. So we have the greater sac and the lesser sac. The greater sac is a very large compartment of the peritoneal cavity, extending all over the abdomen, as we can see here. This that you see here is the greater sac, the greater sac that you see in brown. This is the greater sac. It's a big compartment of the peritoneal cavity, okay? And this that you see behind the lesser omentum, behind the stomach, this is the lesser sac, or the omental bursa. Okay, so the bigger compartment of the peritoneal cavity is the greater sac, and then the small compartment behind the stomach, behind the lesser omentum, is the lesser sac or the omental bassa. This omental bassa, it communicates with the greater sac through an opening. How do we call this opening? We call it the epiploic foramen, as you can see it there, or you can call it the omental foramen. So it's a gap through which the greater sac can communicate with the lesser sac. Remember, these are just compartments of the peritoneal cavity. They just contain fluid. Okay, they just contain fluid. The fluid within the omental bassa can increase. Let's say if a patient has a perforated gastric ulcer, or if a patient has got what, pancreatitis, chronic pancreatitis. This is the pancreas here. So if a patient has chronic pancreatitis, it can increase chances of too much fluid in the lesser sac or in the omental bassa, and that can always be seen sonographically. Okay, within your epiploic foramen, yes, we've said that it's a gap through which your greater sac communicates with the lesser sac, but through that opening, in some patients with loose peritoneal folds, let's say if there is a loose transverse mesocolon, a loose mesentery, it may increase chances of these coils to abnormally herniate through the epiploic foramen. You can see they are leaving their normal anatomical location, going through the epiploic foramen to enter into the omental bassa. We call these internal hernias. When you look at the patient, there will be no swelling anywhere on the abdominal wall, but there will be this internal hernia within the abdominal cavity. Of course, such hernias can lead to intestinal obstruction. This coil may not allow passage of substances or fecal matter, and may lead to abnormal protrusion of the abdomen because of the fact that the contents can't smoothly go through the intestine. Why? Because of an obstruction. But also, since the epiploic foramen is a very small gap, these coils may be strangulated. The blood supply may be cut off, leading to ischemia of these coils that have been herniated. So these are internal hernias. This is one of the location or the site through which internal hernias can occur, the epiploic foramen. Okay, there are more other sites that we shall see later. Now, we can see them now here. We have the duodenum here. Normally, close to the duodenum, there are some potential spaces. Okay, there's a potential space behind the duodenum, potential space on the lateral side of the duodenum, on the left lateral side of the duodenum. This is called the left paraduodenal fossa, or the fossa of Landsat. Herniations can occur through that gap. Herniations can occur through this so-called fossa of Waldea on the right side of the duodenum, and all these, we call them internal hernias. Okay, you can see here part of the duodenum is, and even the jejunum, they are entering the fossa of Landsat, or what we are calling the left paraduodenal fossa, resulting in what we call left paraduodenal hernias. Then you can see here part of the coils are entering the fossa of Waldeia, or what you can call the right paraduodenal fossa, leading to what we call right paraduodenal hernias. So all these are sites of internal hernias. Number one, the piploic foramen, it's a site where internal hernias can occur. Then two, the right paraduodenal fossa, what we call the fossa of Waldeia. Then the left paraduodenal fossa or the fossa of Lanzard. All those sites through which internal hernias can occur. Okay. In all these cases, intestinal obstruction always happens. As you can see, these coils cannot allow easy passage of food substances. So obviously, there will be an obstruction, and this results to so much pain and also distension of the abdomen of this patient. And it requires surgery to reduce these herniations. Okay, so the greater sac is divided into two compartments, the suprachoric compartment and the infrachoric compartment. And this division is attained by the mesentery, by the transverse mesocolon. Okay, so if this is your transverse colon, yes, we know you have the transverse mesocolon there, connecting your transverse colon to the posterior abdominal wall. Above the transverse mesocolon, this whole compartment of the greater sac is called the suprachoric compartment. Below the transverse colon, or below the transverse mesocolon, this whole compartment of the greater sac is called the infrachoric compartment. Okay, the suprachoric compartment, it's up, the infrachoric is below. Okay, so this suprachoric compartment, it's this one up here, above the transverse colon, or above the transverse mesocolon, and it's going to be made up of potential spaces, but it is this whole area here, the suprachoric compartment. So it's going to be made up of potential spaces. Up here on the right and on the left, we are seeing what we call suprahepatic spaces. Suprahepatic spaces above the liver. Okay, these are suprahepatic spaces on the right and on the left. Okay, then of course below the liver we have what we call infrahepatic spaces. So we have one on the right and one on the left. So you can see this is your liver, this is the left lobe. Below that we have the left infrahepatic space. Okay, that space between the left lobe and the stomach. Then on the right side we have the left infrahepatic space, that space between the right lobe and the kidney, the right kidney. You can appreciate it here. Between the right lobe and the right kidney, that is the right infrahepatic space. Or some books can also call it the what? The Morrison's porch, or the hepatorenal porch. The porch, or the space between the right lobe of the liver and the right kidney. Right lobe of the liver and the right kidney. That space is called the Morrison's porch. Okay, it's called the Morrison's porch. You can better see it here. This is the right lobe of the liver, and that's the kidney down there. The space between these two is called the hepatorenal porch, or the Morrison's porch, or you can call it the hepatorenal recess between the right lobe and the right kidney. That is the Morrison's porch. It's an infrahepatic space, but on the right. Okay, the infrahepatic space on the left is this one here between the left lobe and the stomach. But this is more clinically relevant because it is deep, it's large, and it can whenever, let's say, there is a abnormal accumulation of pathological fluids in the abdomen or in the peritoneal cavity, these fluids are going to be to fill the hepatorenal pouch in most cases, because it's one of the deepest pouches within your abdomen. And once this patient stands, of course, this is the lady, this fluid will enter the pouch of Douglas. Once this patient is in the erect position, but in the spine position, there'll be some fluid here, but also more within the hepatorenal pouch. And once you scan this area to look at the right lobe and the right kidney, yes, you'll see that pouch, that hepatorenal pouch, or that Morrison's pouch. Normally, it contains some fluid. The patient has ascites or any other pathological condition resulting into so much fluid production, the fluid here is going to be so much. This is going to be so much between the liver and the right kidney. So out of all these, remember this mostly, because it's what you always be scanning for to confirm pathological fluids in the abdomen. That one there. Always remember that. Always. Then the infracolic compartment. The infracolic compartment, we said it's that compartment that lies below the transverse colon and its mesocolon. So it's this area here. This is the infracolic compartment. Up here we've seen the supracolic compartment. Now here we are going to look at the infracolic compartment. In the infracolic compartment, just a few things to note. We have what we call the paracolic gutters. Paracolic gutters, those are the linear, those are the spaces lateral to the ascending and the descending colon. This is the ascending colon, this is the abdominal wall. The space between these two is the right paracolic gutter. This is the descending colon, this is the abdominal wall. The space between these two is the left paracolic gutter. Okay. This right paracolic gutter is a pathway that is always going to allow fluids to flow from the abdomen down into the potential spaces of the pelvic cavity. For example, the pouch of Douglas in women. Okay, so fluids always mostly use that path. Okay, and it's a path that can allow spread of infections either from the pelvic cavity up into the abdominal cavity or from the abdominal cavity down into the pelvic cavity. Then on the left side, we have the left paracolic gutter. This is going to be separated from the supracolic compartment by a ligament that we call the phrenicocholic ligament. Phrenicocholic. Phrenic means diaphragm. Colic means intestine, the large intestine. So it's a ligament that is going to run from the large intestine to the diaphragm. This ligament, it's a very important one. It will limit spread of infections from the left paracolic gutter into the supracolic compartment. So infections can't spread all the way as it is seen on the right side. On the left side, this limits infections up towards the supracolic compartment from the infracolic compartment. But on the right, there is no guard. But here we have a guard that will limit spread of infections between these two compartments. That guard is the phrenicochoric ligament. Okay, so we've seen the suprachoric compartment. In the infrachoric compartment, we've seen the right parachoric gutter and the left parachoric gutter. Okay, and of course, this infrachoric compartment can further be, of course, separated into the right and the left with the help of this mesentery of the small intestine. The root of the mesentery of the small intestine can help us to separate this into the right and into the left. So broadly, the infrachoric compartment has got the right parachoric gutter, the left parachoric gutter, the right infrachoric compartment, and the left infrachoric compartment. Okay, so that is the infrachoric compartment. And all these two were subdivisions of the greater sac. Now the lesser sac, we also called it the omental bursa, and we said it's going to be lying posterior to the stomach and the lesser omentum. Okay, and it's going to allow some degree of movement of the stomach. Remember, whenever a stomach is filled with food substances, it can distend. Okay, it can do what? It can distend, and its distension is permitted because of the presence of this big space behind it, the space that we are calling the omental bursa or the lesser sac. Okay, so this is your stomach. When you reflect it, there is that big space behind it, the space in front of these structures that you see here, behind the stomach. That space is the omental bursa. How do you enter it? You enter it through the epiploic foramen. Okay, so through this gateway, inside, this is what you will see. There's a whole space there containing fluid, peritoneal fluid. Okay, and we said the fluid in here can increase if, let's say, patient has a ruptured gastric ulcer or chronic pancreatitis. In patients with chronic pancreatitis, inflammatory fluid can accumulate in this space. Patients with a ruptured gastric ulcer, the fluid will accumulate in this space, and that is always a sign or feature that is appreciated by ultrasound. Okay, so that's the omental bursa, and you can see once again it's entered using that opening that we've called the omental foramen or the epiploic foramen. And surgically, let me just mention this, surgically, this opening here can be accessed. And remember, within the less omentum, we have some blood vessels that go through in the hepatoduodenal ligament. We have the portal vein going to the liver. We have the hepatic artery going to the liver. Okay, so surgically during surgeries of the liver, these vessels can be squeezed to reduce supply of blood to the liver during surgical operations. Okay, and that will limit overbleeding whenever there is need to surgically operate on the liver. So this is called the Pringles maneuver. It's a surgical maneuver that intends to temporarily occlude the blood vessels that take blood to the liver. Okay, I won't overspend time on this, but I just mentioned it. All right, so we've seen the greater sac, okay, and the lesser sac or the omental bursa. And finally, let's end our session by talking about ascites. So ascites, it's a term used to mean excessive fluid within the peritoneal cavity. That's what ascites means. There are several factors or causes of ascites. Number one, it can occur in kids who are malnourished. Anyone to explain this? Why it will occur in kids that are malnourished? By show of hands, anyone to give us an explanation to that? Why do you think it can occur in kids that are malnourished? Anyone to tell us? Now, Michael, you're asking what causes ascites. We are on the causes. The causes are listed there, and we want to tackle one by one. And I'm asking you, I have told you that malnutrition can lead to ascites. I've told you what ascites is. Excessive accumulation of fluid in the peritoneal cavity. And I'm saying one of the causes is malnutrition, and I want someone to throw more light on that. Agnes. Agnes?
We usually get kids with kwashiorkor having an enlarged belly, and I think it's due to lack of proteins. And we have some proteins which help in fluid balance, like albumin. And if it's low in the body, we shall get accumulation of fluids from the blood vessels into the abdominal cavity, leading to ascites or enlargement of the abdominal cavity. That's what I can say about it.
Thank you very much. Okay, so mostly those kids that are protein malnourished, kids with kwashiorkor, they have less proteins. Proteins are needed in blood to prevent excessive filtration, okay, or prevent fluids from oozing out from your capillaries. In this case, the capillaries around or within your abdomen. So if the proteins are less, obviously, there will be a reduced oncotic pressure, and it can easily result into leakage of fluids into the peritoneal cavity. So that's why these kids always present with a distended abdomen with ascites. Okay. 2. Ascites can occur in patients with liver disease. Let's say this person is an alcoholic, or let's say this person unfortunately has viral hepatitis, or is those patients, they are going to present with ascites. Or if a patient has hepatocellular carcinoma, okay, these patients are also going to present with ascites, because usually whenever there is a carcinoma or whenever there is scar tissue in the liver, or what we call cirrhosis, as a result of hepatitis, whether from a viral or an alcohol causing factors, all those scenarios lead to scar tissue within the liver, and that scar tissue in the liver usually blocks the blood channels in the liver, the sinusoids. And last time I told you, whenever they are blocked, blood will tend to flow backwards. Blood will flow backwards into the portal vein to overfill the tributaries of the portal vein. Blood will overfill the spleen, and these patients will present with a big spleen, or what we call splenomegaly. Blood will stay for a long time in this portal vein, and that increases the portal venous pressures that can easily increase chances of fluids oozing out of the small capillaries. And if the fluid oozes out in large amounts, of course this patient is going to present with ascites. Okay, so usually patients with liver cirrhosis as a result of, let's say, excessive alcohol consumption or the result of viral hepatitis, or patients with masses in the liver, those masses can obstruct blood vessels, and always these patients lead to or present with ascites. Then patients with peritonitis, this means inflammation of the peritoneal membranes, could be as a result of leakage of contents from the pancreas in patients with chronic pancreatitis. Could be because of an inflammatory bowel disease. Okay, these patients are going to present with they are going to have peritonitis if there is inflammation of the peritoneal membranes. These membranes can increase amount of fluids within the peritoneal cavity because of the inflammation. We know that whenever inflammation goes on, fluids are produced. So patients with peritonitis can also have or can also present with ascites. Patients with kidney disease can present with ascites. We know the kidneys are important in eliminating excess fluids from the body. So if the kidneys are diseased, these fluids will be retained within the body, and these patients can present with not only edema of the lower extremities, but also ascites. Some of them can present with ascites. If someone's heart is failing, blood will be dragged in the lower parts of the body, and that increases the pressure is in the veins and capillaries of the lower parts of the body, and these patients usually present with edema but also with ascites. So all these are factors that can lead to ascites, and ascites can easily be appreciated radiographically on X-ray, but also on a CT scan, as you see here. This is the liver. You can see that there's so much fluid. There's so much fluid around it. It can be appreciated sonographically very well. So that marks the end of our session, and this has been a brief session telling us about the peritoneum. We have looked at what it is. We have looked at the two parts of the peritoneum and their locations. We have looked at their extensions, the peritoneal folds. We have looked at the potential spaces. We've looked at a few clinical correlates regarding this topic. Do we have questions before we end? Yes, Apofia.
Excuse me, sir. I saw
Yes.
somewhere when they are saying that the greater momentum is four-layered. What do they mean? And the
Yes.
second question is, under the parts
Yes.
of the layers of the peritoneum, there is a textbook that mentioned three. There is interperitoneal organs that are covered, half of them. That layer covers half of them.
Okay, so the great momentum, yes, it has four layers. Okay, well, I didn't want to go into depth of it. Yes, you can see this layer in front of the stomach, behind the stomach. These two, they are the anterior, they make the anterior portion of the great momentum. Then they are going to fold and extend to the transverse column. So that makes it to be four-layered. That's the meaning of that statement. So the two layers in front and the two layers in the posterior aspect go extending to the transverse column. Okay, makes this to be 4-layered. Okay, and then this is just double layered. Okay, then the other question was about the organs. Yes, the organs of the abdomen, they can be categorized. We've categorized them into the intraperitoneal, those that are almost covered by the peritoneum. Okay, we have those that are totally behind the peritoneum. These are retroperitoneal. Okay, to be specific, you can call these primary retroperitoneal organs. And then we have what we call the secondary retroperitoneal organs. Those are the organs that were initially intraperitoneal, but because of the rotation of the gut during development, these structures were made to attach on the abdominal wall, and they gained a retroperitoneal position. They were initially intraperitoneal, but because of the rotation of the gut during development, these organs became attached on the abdominal wall, and they regain a retroperitoneal position. So such organs that were initially intraperitoneal but later gained a retroperitoneal position, those organs are called secondary retroperitoneal structures. For example, the ascending colon and the descending colon, the first part of the duodenum, the tail of the pancreas. Those structures are secondary retroperitoneal structures. I just didn't want to go into depth of that, but yes, you can categorize this into two. We have the primary retroperitoneal structures. Those are the structures that were behind that are situated behind the peritoneal, but behind the peritoneum during development and after the embryological development. The kidneys, the blood vessels, okay, the adrenal glands, the ureters, those are primary retroperitoneal structures. But the ascending colon, descending colon, the duodenum and pancreas, these structures were initially intraperitoneal, but because of the rotation of the gut, they regained a retroperitoneal position. That's why you can call them secondary retroperitoneal structures. Apophia, is that clear? Apophia, is that
Yes,
clear to you?
yes, thank you.
Okay. Nakawi Agnes, she's requesting for more light about the transverse and the sigmoid mesocolons. Those two were clearly talked about. We say that the sigmoid, the transverse mesocolon, is going to suspend the transverse colon from the posterior abdominal wall, and then this suspends the sigmoid colon from the pelvic wall. This is the transverse mesocolon. It's connecting this indirectly to the posterior abdominal wall, making it to be freely hanging in the abdominal cavity. Then the sigmoid colon, it's going to attach this to the, it's going to be connected to the pelvic wall or to the abdominal wall, and this allows your sigmoid colon to freely hang within the pelvic cavity. So for as simple as that, transverse mesocolon, sigmoid mesocolon. Agnes, I hope that is clear to you. Couch Godfrey. Couch Godfrey. Jessica is not speaking. Lastly, I can call Agnes. Agnes, let's hear from you.
Yes. I was asking that
Okay.
we have seen that
Coach Godfrey, use this minute to text that question. Your network is not good. As we hear from Agnes. Agnes, you have any more question?
Yes, sir. I would like to ask about the urinary bladder. There is some I read and they are saying it's a subperitoneal organ. So I don't know.
The urinary bladder is, if we look at it here, the urinary bladder is, it is extra, or to be specific, it is subperitoneal. Subperitoneal. It is below the peritoneum. It's below the peritoneum. So it's a subperitoneal structure or organ. Okay. These are intraperitoneal, these coils. Okay. These are retroperitoneal, the blood vessels, the pancreas, the duodenum. Okay. But these below the peritoneum are subperitoneal. Agnes, is that clear?
Yes, sir. Thank you.
Now, Ayebal is asking, does the peritoneum also extend into the pelvic cavity? Ayebal, I think you have just joined now. Can anyone answer him? Can anyone answer Ayebal, Brian?
Yes.
It extends. Ayebal, you go through the recording. If you fail to understand, you can always text me. Okay, so let's end here. Someone is asking here, can the pleural cavity be filled with gas? Now, how did we reach the pleural cavity? We already covered the pleural cavities. Yes, we say they can be filled with excess air. Okay, and I told you to appreciate that by covering or by looking at the different types of pneumothorax. Coach Godfrey, I'm giving you a task of reading about the different types of pneumothorax to understand that. Okay, so let's end here. That was a brief session, very easy. Let's meet again next week on Monday. Read about the esophagus, the stomach. Now we are going to the visceral structures of the abdomen. Okay, that's what we shall be covering on Monday. Have a good morning.